Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing sedation and paralysis. The reason that we're discussing sedation and paralysis today is that sedation and paralysis are used in many different patient care settings, particularly in the inpatient setting as well as some outpatient settings. For example, outpatient surgery. It's important to know what sedation and paralysis agents are used commonly in practice, and as well as their clinical applications as a pharmacist. Our objectives today will be to list indications for sedation and paralysis, define tools used to monitor sedation and paralysis, compare and contrast pharmacologic agents used for sedation and paralysis, describe sequential administration of sedation and paralytic agents, and then review evidence-based recommendations from guidelines and other evidence for sedation and paralysis. We're going to start off with a patient case. We have a patient HP who's a 62-year-old female presenting to the emergency department with shortness of breath. She was just diagnosed with heart failure a couple of months ago and has been eating out at McDonald's every day. Vital signs upon admission include blood pressure 128/62, respiratory rate 28, elevated, heart rate 120, and oxygen saturation 89%. Past medical history is significant for end-stage renal disease in addition to heart failure. She requires intubation and mechanical ventilation with need for sedation and paralysis due to acute respiratory failure. Which of the following medication sequences demonstrates proper sedation and paralysis for HP's intubation? Cis-atracurium, then fentanyl, propofol, then dexmenatomidine, succinylcholine, then morphine, medazolam, then rocuronium. After intubation, HP requires continuous sedation. Which of the following is most appropriate? First line, continuous sedation for HP: dexmenatomidine, fentanyl, Lorazepam, or morphine. And then which of the following is the most appropriate RAS goal for patient HP? Is it +2 to +4, 0 to +2, -2 to +1, or -3 to -5? After we discuss sedation and paralysis today, you should be able to answer each of these questions with relative confidence. So we're going to first start off with sedation. So why do we use sedation? What is sedation? And how do we go about this as a pharmacist? So just to give you a little background on sedation, we have agitation and anxiety occur many times in the inpatient setting, and particularly in intensive care unit patients. And intensive care unit patients are patients that need continuous nursing monitoring at minimum every 15 minutes to make sure that they do not decompensate very quickly. These patients may have a significant amount of agitation and anxiety related to the phenomena that is going on around them. They are in a hospital setting potentially. They are having lots of, potentially sounds, alarms going off. They might get pricked every few hours to get a blood level or to administer a medication. It's a very not pleasant situation. And prompt identification and treatment of agitation or anxiety may have negative consequences. Obviously, we want to make sure that the patient is comfortable during their stay in a hospital or even an outpatient setting, such as a surgical setting where they might be using sedation. But we also realize that treating this agitation and anxiety might also obviously have consequences, because if you give a drug for something, you can always have a consequence. So sedation may be indicated in patients with agitation or anxiety, or patients at risk for agitation or anxiety, particularly in the intensive care unit, but this can also apply to other settings such as surgical settings, as well as inpatient and outpatient. So here we actually have what is known as the pain, agitation, and delirium triad. And what we see here are many of the different etiologies and causes that can cause pain, agitation, and delirium within a hospital setting or an outpatient setting. In terms of pain, which you are already familiar with from previous class days, you have different reasons for pain. Now, particularly in the hospital or a surgical area, you might have different reasons for pain than just chronic pain. You might have an IV line where you might have a catheter stuck up into tissue, and that might cause a little bit of pain. You might have tissue injury from other phenomena such as surgery, trauma. You might have pressure areas, you might feel uncomfortable. Say, if you have the example of you're lying in bed and you're not very comfortable, that might induce a little bit of pain. You also have an endotracheal tube that is potentially down your throat if you are intubated. And one common phenomenon where we hear about intubation and mechanical ventilation right now in the media is COVID-19. A lot of COVID-19 patients who have severe COVID-19 have to be intubated or have a tube placed down their throat and hook that tube up to a mechanical ventilator to assist them in breathing. You also have different elements of ICU and hospital care that can obviously cause pain. Whenever a patient undergoes physical therapy, if they're turned, any of these things can cause pain. And essentially, we want to make sure that we can control that pain as much as possible. We might not be able to completely, obliterate the pain, but we want to make sure that the pain is manageable and that the patient can be in a relative alert and calm state. Pain also influences agitation, and obviously we all know what agitation is. It's basically an unpleasant awareness or an unpleasant sensation. And this can happen for a variety of reasons. We might become agitated. We might become agitated from anxiety or stress, frustration. If we're hungry or thirsty. If we're trying to breathe and we're having issues breathing. And that can be assisted breathing with a ventilator or basically non-assisted breathing, just breathing on room air. Inability to communicate. Some patients are not able to communicate even though they would like to, and that might cause severe agitation in some patients. If they are physically restrained, and sometimes patients in the hospital have to be restrained because they might cause a potential danger to themselves. If they have a tube down their throat, like an endotracheal tube, they might want to pull that tube out. And obviously that tube might be helping them live by basically facilitating their oxygen and carbon dioxide exchange. So we don't want them to remove that tube, or else they might pull it out and then they might have a hypoxic episode and potentially stop breathing. We also have other phenomena that cause agitation. Like I said before, noise is a big thing. If you don't have enough sleep, you might become agitated. Think about, in the morning whenever you wake up. If you didn't get enough restful sleep, and even if you did get restful sleep, you might feel a little bit agitated. And that's perfectly normal. We all have a little bit of agitation here and there, but it's not to the point where a lot of times where we would basically go out aggressively and try to potentially hurt ourselves or hurt someone else. Patients may be under the influence of different substances, or they might even be withdrawing from different substances. And you've talked about different substance abuse disorders in this course. You might have also withdrawal from regular medications that are not necessarily illicit drugs. And that can obviously cause a little bit of agitation too if the patient is not getting those things. You also have delirium, and delirium is basically more or less an acute state of confusion versus dementia or Alzheimer's disease, a specific type of dementia, where the delirium is chronic. Delirium here is basically an acute perception of reality that might not necessarily be reality. And that can obviously also be influenced by pain and agitation. Obviously, if a patient, has certain past medical history, such as dementia, if they are advanced in age, if they have any mental impairments, trauma or head injuries, even if they have, something along the lines of hypoglycemia, which is a very simple thing, whenever we think about it, might be induced by not eating or by medications such as insulin therapy. If they have a low blood sugar, for example, that might cause them to be at an altered state of consciousness. They might not know what's necessarily going on. And as a result, they might, acutely be delirious until that problem is fixed. One thing to keep in mind with all of these different etiologies is that we want to try to fix each of these things if we can. Some things are obviously not fixable. Say if you have an endotracheal tube down a patient's throat and they still need that for breathing, and they might not be able to take that out until the patient's lungs are able to heal properly. You have to leave that there. But we want to try to control each of these different factors as best as we can, if possible. And remember that non-pharmacologic treatment is always a very important factor. But whenever non-pharmacologic treatment is going to, basically not be enough, we might need medications to treat pain, agitation, and delirium. So in regards to sedation, and this picture right here on the right actually shows you what that endotracheal tube that I was referring to actually looks like from the previous slide. It's just a simple tube. It goes down into the mouth and then into the esophagus area, and that tube allows the patient to have a breathing pattern. That end of the endotracheal tube is hooked up to what is called a mechanical ventilator, and that ventilator may be set at different modes to help the patient breathe. And this can be a life-saving intervention in patients who have acute respiratory failure or other types of respiratory distress. So in regards to sedation, why do we need to sedate people? There are many different reasons. The main reason that we sedate people, at least in the inpatient setting, is for an intubation. Obviously, the phenomenon of sticking a tube down someone's throat is something that you don't want to be awake for. It's very unpleasant. It's not fun. And you would most likely want to be asleep for that. Therefore, we will sedate patients, at least for an intermittent time before we can actually provide prolonged sedation to those patients. We might sedate patients if they, have any other types of danger to themselves. Say if they're in severe pain and they're, basically thrashing around and very agitated. If they have delirium, they don't know necessarily what's going on. They can't protect their airway. They can't, think about breathing on their own, or they're not breathing on their own. Those might be, potential reasons why we might intubate someone and sedate them. If a patient is hypoxic, if they are hypoxic, we will a lot of times intubate them and put them on other oxygen therapy. They might also require sedation for that. Hypoglycemia is one we mentioned before. If they're acutely ill, like hypotension, for example, if they're in shock, and hypotension might, cause to an extent a degree of altered mental status from lack of blood flow to different areas, including the brain. If you are having different withdrawals from either illicit drugs or non-illicit drugs, and that also includes alcohol, you might need to be sedated to basically minimize the danger to yourself, or to basically minimize that agitation. If you have an inability to communicate, that might be a reason for someone to be sedated, especially if we don't know necessarily what they're saying, or if they are trying to communicate to us, in nonverbal form that they're having a lot of distress. We might need to sedate them. We might need to sedate people for physical restraint. Say if they are a danger to themselves, and a lot of times I think about acute psychiatric patients in this case. We might need to physically restrain them with chemical sedation, and chemical sedation in this case could be a medication. Surgery or other procedures, very other common reason for sedation. patients may or may not need to be intubated for different surgical procedures. And if the procedure is going to cause pain or agitation of the patient, the provider is most likely going to provide some type of sedation, either most of the time IV, but they might also provide PO sedation beforehand as well. And there are many other reasons for sedation. One of the big sedation indications that we're going to focus on today is intubation, as well as the prep for potential surgery or procedures which may require intubation. Those are the main things that we're going to focus on today, but if you have any of these other things, this might also require an intubation. So just keep that in the back of your mind. How do we monitor sedation? So obviously we have subjective and objective ways that we can do this. We want sedation to ideally be titrated to light levels, where the patient can still be arousable and follow commands most of the time. There are cases, though, where we want sedation to be at deep levels, where the patient is unarousable and unresponsive to painful stimuli. Sometimes we might not want them to be awake at all, say if they are getting intubated or if they are on a paralytic agent. We'll talk about paralysis in a little bit. But like I said, most of the time we prefer light sedation over heavy sedation. And the main reason we prefer light sedation over heavy sedation is that there are less complications that can occur whenever you are lightly sedated versus heavily sedated. A lot of these medications can accumulate over time and cause many different adverse effects to occur. And obviously, whenever you have more of a drug in a system, particularly a sedative, it might be harder for a patient to wake up. And that can increase someone's hospital length of stay as well as intensive care unit length of stay if they are in the hospital. And it might also be more related to mortality as well as acute delirium. And again, the exception to light sedation would be continuous paralysis. And the reason why we don't do light sedation in a patient who is paralyzed, and we'll talk about paralysis in a little bit in the second part of this presentation, is because if you are paralyzed, you are not able to move, you're not able to talk. You're not able to basically give the same, typical expressions that we would normally. And if you're not sedated heavily during this, it's almost like you are, in a state of petrification. You basically can see everything, but you cannot respond. And that can be very terrifying to someone. Some people say it's the worst thing that can ever happen to them is if they are paralyzed, but not sedated enough. And if they're even lightly sedated, where they might have the ability to just be awake and alert, it might be a sensation of just, pure terror, because everything going on around them might, basically be sensory overload to them. They might, basically be freaked out because they can't respond to you. They're kind of stuck in their bodies, more or less, and they're not able to actually render a response. And that's kind of terrifying. Two main monitoring tools that we use that are guideline recommended by the 2018 and the 2013 sedation guidelines are the Richmond Agitation Scale, or the RASS, and the Riker Sedation Agitation Scale, or the SAS. And these are two tools that have high sensitivity and high specificity per the guidelines for monitoring sedation. So the Richmond Agitation Sedation Scale, or the RASS, is one of two sedation scales that we consider the most valid and reliable in addition to the SAS. And the thing that's important to know here with the RASS is that it is based on a scale of -5 to +4. Numbers below 0 indicate patients who are sedated. So basically more on the sleepier side if you are below 0. So if you have a negative number, -1, -2, -3, -4, -5, that indicates a level of sedation. -1 would be less sedated than a -5, where -5 you were completely out. Numbers above 0 indicate agitation. So +1, +2, +3, +4. +4 is basically the worst agitated that you can be, or the highest level of agitation you can be, where essentially you are a danger to self, you might be fighting people. It's not a good situation. And 0 in the middle indicates alert and calm. So this is actually what this scale actually looks like. Now, it's not necessarily important to know what each individual level is in terms of combative, very agitated, restless, alert, and calm as you go down. But what is important to know is that 0 is alert and calm. That is what you need to know. And you also need to know that the numbers above 0 that are positive are basically agitated, and the levels below 0 or the negative numbers are the sedation levels. That's what's most important to know about here. And whenever we talk about light sedation, typically per previous set of guidelines, which were the 2013 guidelines, they actually considered a level of light sedation to be 0 to -2 here. Now they actually include +1 or restless in that, because they have basically determined that a +1 or restless is also acceptable in regards to being at a level of what they consider to be light sedation. It's acceptable to be a little restless, but they don't want it to get to the point where the patient's actually agitated. And then for our deeper levels of sedation here, we have -3, -4, and -5. So moderate, deep, and cannot be aroused. Depending on the providers, the providers, what they do with the patient. So say if they talk to the patient, for example, and the patient briefly awakens with eye contact to voice for less than 10 seconds, they might consider that a light level of sedation with a score of -2. You see here that this scale is subjective to an extent, but it's also objective in regards to us actually putting numbers next to the phenomena that occur. And nurses actually use this scale whenever they are titrating medications, particularly sedation medications, obviously. So it's important to know basically the general range of this scale. Know that 0 is alert and calm. Anything above 0 is agitation. Anything below 0 is sedation, and that our general goal for most patients, except for those who are on continuous paralysis, is a -2 here, light sedation, to +1 where you are restless. The microsedation agitation scale is the other validated sedation scale. And this one is the one that's not used as much in practice from what I have seen in my experience. All you need to basically know here is that the scale is based on a number of 1 to 7. There are no negative numbers here, and there's no 0. In this case, 4 indicates alert and calm. So 4 is the middle of the scale, like 0 was for the RASS scale. Numbers below 4 indicate sedation, and numbers above 4 indicate agitation. And you see here, it's very, very similar to the RASS scale. The main difference is that the numbers are different and the amount of actual levels is different. Here you actually have less levels than you did with the RASS, which was -5 to +4, which basically indicated that you had basically 10 levels. Here you only have 7. And the most important one to know here is the score of 4. The 4 is basically where you are alert and calm. Anything above that, you are agitated. Anything below that, you are sedated. And for light sedation, we typically aim for a goal of 3 to 4. 3 to 4. Sedated or calm and cooperative. If you are a score of 2 or 1, that is very sedated or cannot be aroused. If you are, again, above 4, you are agitated. And you will tell here that agitated on this scale is a score of 5. On the RASS scale, it was actually a positive 2. So it's actually not acceptable for a patient to be at a positive 5. If they were at a positive 5, we would consider that unacceptable, and we would want to try to increase their sedation amount. And we'll talk about that a little later. Okay, so what are our sedation pharmacotherapy options? We have many different things that we can sedate patients with. We have opioids, we have benzodiazepines, which are all drugs that you've already heard of in the previous classes. And we also have sedation agents. We have Propofol, Dexmonatomity, Atomidate, and Ketamine, some of which you have actually heard of before, but you may have not heard about them in the context of sedation. And so what we're going to do is we're actually going to explain each of these drugs and their individual kinetics, their onsets of action, what are some special considerations, and what are some adverse effects regarding these medications. It's important to keep in mind that on the following slides that a lot of the information that you have on these slides is going to be more attuned and related to sedation. So I'm not going to list out every single adverse effect of each of these drugs. All of the previous adverse effects you've learned for the opioids apply. But I'm going to list ones that are mainly relevant for the purposes of inpatient setting and for the sedative as a whole. So with that, we're going to start off with opioids first. So we have morphine as our first opioid, and opioids are mu agonists. They basically activate the mu receptor and basically relieve pain. And morphine is available IV for pain and or sedation, and it obviously has its PO analogs as well. Our onset and intermittent dosing are 5 to 10 minutes for onset after you give the IV dose, and we typically can give 2 to 4 milligrams every 1 to 2 hours. Sedation maintenance doses anywhere between 2 and 30 milligrams per hour, but that dose can actually be exceeded above the 30 milligrams per hour, particularly for patients who are going into comfort care. And what comfort care is basically a family or the patient has basically decided that the patient who is currently, on a life-sustaining therapy, such as mechanical ventilation, would basically like to more or less die in peace. And would not like to, further go along with further hospitalization or mechanical ventilation or other life-saving maneuvers or measures. And, a lot of times it does, obviously take a lot of resources to take care of these patients in the inpatient setting. But the thing that you have to think about too is the amount of suffering that might actually go on when a patient is, actively dying. We have all these sedation agents and they're great and they can keep patients relatively calm, but ultimately at the end of the day, if you are, on mechanical ventilation and there is, minimal hope for some patients who are mechanically ventilated and just so sick, they might choose to go on comfort care. So they will actually terminally extubate the patient. So they'll take the breathing tube out of the patient, place them on a morphine drip for pain and relaxation, and to basically relieve them of any kind of, agitation that they're having. And they might titrate that dose up as far as the patient can tolerate. It's basically providing pain and a degree of sedation. Now, with each of these opioid agents that we're going to talk about IV-wise, the adverse effects are the same, but the degree to which you have some of these adverse effects is different. So I want you to keep that in mind. With morphine and the opioids that are given IV, you can develop hypotension and respiratory depression, pruritus or itching, and constipation. So whenever you are basically receiving morphine chronically or over many intermittent doses, it might be worth it to consider a stool softener such as Docusate or a stimulant laxative along with that, such as Senna or Bisoprolol. Some considerations with morphine specifically is that it has significant histamine release. So whenever that histamine is released, that actually increases risk of hypotension or greater degrees of hypotension and greater degrees of pruritus from occurring. And because of that increased hypotension and pruritus, morphine is actually not the preferred agent that we typically use in sedating patients who are intubated. We do use it for patients who are on comfort care, though, because it does provide great analgesic and sedative effects for our patients who are on comfort care. But in general, though, you might use morphine typically intermittently for sedation if patients can tolerate it. But in an intensive care unit setting, we tend to stay away from morphine just because it has the greater histamine release and increased risk of hypotension and pruritus. We have accumulation in hepatic and renal impairment for morphine, so it's important if you have a patient that has liver disease or kidney disease that you're obviously aware of about that, and you might have to dose that patient a little bit less. And like we said before, continuous IV infusion of this medication is used in comfort care. So if a patient, has decided that they would like to, pass away on their own with nature's calling, more or less, they can basically be put on a morphine continuous drip that's titrated all the way up to the patient's satisfaction. Hydromorphone is also an opioid known as Dilaudid, and it is also a mu agonist. It's used for pain and sedation. You see here again the onset, intermittent dosing, and sedation maintenance dose. Quick onset, you can intermittently dose it every 1 to 2 hours, and it has a sedation maintenance dose of 0.5 to 3 milligrams per hour. Adverse effects, same as fentanyl. But because hydromorphone induces less histamine release than morphine, it has less hypotension and less pruritus than morphine. These agents still will cause respiratory depression, and particularly when given over chronic periods of time, over the course of days, can actually cause constipation. So again, stool softener, stimulant, laxative, important. You can accumulate hydromorphone or Dilaudid in hepatic and renal impairment, just like morphine. Here, it's important to note that a lot of times the continuous IV infusion will actually require mechanical ventilation. And the one exception to this would be in a patient who might have an allergy to morphine. And whenever I say allergy, I'm talking about real allergic allergy like shortness of breath, anaphylaxis. They may consider hydromorphone in those cases for comfort care, but they might alternatively use the next agent that we will talk about for comfort care, which is known as fentanyl. And you're probably familiar with fentanyl in regards to pain control for chronic pain patients in regards to the different dosage forms that are available, particularly the most common one probably being known as the patch. But we also have IV fentanyl that's available and for pain and sedation. And its onset's really quick. You can actually titrate it to very high doses, assuming that the patient is mechanically ventilated. And again, exception to this is for comfort care. If they're going comfort care, you don't have to necessarily be mechanically ventilated. So adverse effects here, same as before. The considerations here for fentanyl is that it does have minimal histamine release. So as a result of it having minimal histamine release, it is the preferred opioid for continuous sedation. This is our workhorse in the intensive care unit if we intubate a patient, because it will have the least risk of hypotension and the least risk of pruritus. They're not going to itch as much, and they may not necessarily become hypotensive as much. You still have a degree of histamine release that is there and can still cause those symptoms, so it's always important to be aware of that, particularly with the hypotension. Intensive care unit patients and hospital patients can be relatively unstable, and they can become hypotensive for almost, it seems, any reason, particularly with medications. So you always want to keep that in the back of your mind. But we use fentanyl more in the intensive care unit over hydromorphone and morphine because of its minimal histamine release. And that's a very, very important point to know, hint, hint, star, star. The next class that we'll talk about is the benzodiazepines, which you're also probably very familiar with. The ones that we'll focus on for IV sedation are Lorazepam and Medazolam. So Lorazepam, or Ativan, is a GABA agonist. It's basically inhibitory in nature because of its GABA agonism. And you can actually give it IV or IM for sedation. Typically, we give it IV, though. It's onset after the loading dose. It's about 15 to 20 minutes, so it's a little bit slower, but once it gets started, it functions pretty good. Some of the adverse effects you have to be concerned about here are obviously hypotension and respiratory depression. We always are concerned about these with a lot of our different sedative agents. The other big thing that we're concerned about in terms of a hospitalized patient or an intensive care unit patient is delirium, so an acute state of confusion. And this typically will develop over longer periods of getting a benzodiazepine agent. Benzodiazepines such as Lorazepam and Medazolam, when given continuously or as intermittent boluses over time, can be associated with ICU delirium. All sedatives can be technically related to ICU delirium, except for dexmonatomity, which we'll talk about in a moment. But the class that has the biggest risk of delirium are the benzodiazepines. So Lorazepam, Medazolam are typically the things that we want to watch out for. And this is why they're not as preferred as much for continuous sedation. But if you have to use them, you have to use them. And there are some indications where we have to actually use these as first line. Some considerations are that we typically dilute IV Lorazepam 1:1 with normal saline or sterile water for injection. The IV formulation contains propylene glycol. And if you remember all the way back from acid-base with the anion gap metabolic acidosis, propylene glycol is actually the P in mud piles. And as a result of that, can actually cause an anion gap metabolic acidosis. So we don't want to be on continuous infusion of Lorazepam for too long. Typically, a lot of institutions will cap their IV continuous infusion of Lorazepam at 48 hours max. After 48 hours, they need to transition to something else, because if they are on high-dose IV Lorazepam for too long, it can obviously induce that metabolic acidosis, and obviously complications of acidosis can occur, such as hypotension. Continuous infusion of Lorazepam does require mechanical ventilation. So if you do have a patient who's obviously not on comfort care, we want to make sure that you are mechanically ventilated if you're on a continuous benzodiazepine or you're on a continuous opioid. If you are not on comfort care, if you're on comfort care, then obviously those rules don't apply. But we do that because we don't want the patient to basically have respiratory depression off of the vent. If they're on the vent, then obviously we're supporting their lungs. If they develop, respiratory depression from too much sedation, we at least have the vent to support them. If they're, on these drips without mechanical ventilation, which can be very dangerous, and I've seen that happen a couple of times, then obviously you place the patient at risk for a cardiopulmonary arrest, and that would not be a good situation. Medazolam is the next benzodiazepine that we're going to talk about. It's known as Versed. It's a GABA agonist. It's available at IV or IM for sedation purposes. Onset is very quick, 2 to 5 minutes. You can give loading doses or intermittent doses. You can give maintenance doses as well. Same adverse effects as before: hypotension, respiratory depression, delirium. And because of the respiratory depression component, it does require mechanical ventilation if it is continuous. If you're giving like little boluses of it, you may or may not necessarily need to be intubated. It does rapidly redistribute in the body. It has an active metabolite. One big thing with Medazolam is that it is renally eliminated, so obviously adjustment in renal patients or less sedation in renal patients with Medazolam may be necessary. And those are kind of the big important points to think about with Medazolam specifically. We also have other sedatives other than the benzodiazepines and the opioids that we mentioned before. One common sedative that we use in procedural areas as well as the inpatient setting is Propofol, also known as Morphine. And it's a GABA agonist and an NMDA antagonist potentially. The question mark there is because we don't necessarily know in what degree that these mechanisms of action actually occur. Its onset after the loading dose is about 1 to 2 minutes. We do have sedation loading dose and sedation maintenance dose here for you as well. Adverse effects of Propofol are, very prevalent. With Propofol specifically, you can develop hypotension similar to the other agents that we've talked about. Bradycardia, so a lowering of the heart rate. Respiratory depression. So again, this also requires, if you have a continuous IV infusion of it, to be on mechanical ventilation. Again, you can get intermittent bolus doses of Propofol in procedural areas and not have to be mechanically ventilated, but a continuous infusion will require mechanical ventilation. There are other, potential effects. You might have cardiac failure related to the hypotension bradycardia, or even a syndrome called propofol-related infusion syndrome, or PRIS. And basically what propofol-related infusion syndrome is it's not necessarily a specific disease state, but it's a constellation of symptoms that occur from extended use of propofol or very high doses of propofol. So if you're giving propofol for typically greater than 48 hours, for example, we obviously will want to minimize the use of propofol when possible, because you may develop a constellation of these different symptoms that you see here: cardiac failure, rhabdomyolysis, metabolic acidosis. Propofol-related infusion syndrome has a very, very high mortality rate. So typically, if you're giving propofol for greater than 48 hours and at higher doses, typically at or greater than 50 micrograms per kilo per minute, and you can give outside of this range. I have seen patients go all the way up to 100 micrograms per kilo per minute. It can be potentially, fatal. For the acute phase, it's okay. It's not necessarily deadly to, intermittently go up to 100 mics per kilo per minute if you need to, but that dose needs to be brought down. Important considerations to be made with propofol, in addition to requiring mechanical ventilation, is that the lipid emulsion contains 1.1 kilocalories per ml. And you see here that this substance is actually white and milky. And that's because it's contained in lipid emulsion. And that's basically it's emulsified in lipids to basically be given to the patient. As a result of being, in a lipid emulsion, we need to monitor, different monitoring parameters such as serum triglycerides. We want to make sure that the triglycerides don't get too elevated in our patients. So, if they go above 400 or 500 milligrams per deciliter, that's usually a concern that the patient can eventually develop pancreatitis from hypertriglyceridemia. So we want to minimize that risk whenever possible. And again, like we talked about, continuous IV infusion requires mechanical ventilation. Dexmonatomity is the next sedative agent that we'll talk about. It's also known as Precedex. And Precedex is an alpha-2 agonist. So the medication that's commonly thought of as an alpha-2 agonist that's commonly used is clonidine. So it actually works the same mechanism as clonidine as an alpha-2 agonist centrally. Its onset after a loading dose is 5 to 10 minutes. Not all patients will receive a loading dose, however. And we have sedation maintenance dose that's typically ranging anywhere between 0.2 micrograms per kilo per hour to 0.7 micrograms per kilo per hour, though you might actually exceed that 0.7 and go all the way up to 1.5 micrograms per kilo per hour, as that dose also has been studied. But general maintenance range is typically 0.2 to 0.7. Some adverse effects that can happen from dexmedetomidine administration are hypotension and hypertension. The hypertension typically happens after giving a bolus dose. What will happen typically is that obviously because this is an alpha-2 agonist, it will cause hypotension. So what can happen acutely is as you give that bolus dose, you might become acutely hypertensive for a little while after that bolus dose is given as a compensatory mechanism. And then that blood pressure will actually, probably go a little bit lower because of the alpha-2 agonism that can occur. That is obviously similar to clonidine. You also have bradycardia related to this agent, so it's very important to watch the heart rate in these patients. Some considerations is that it does not cause significant respiratory depression, unlike our other sedatives. And because it doesn't cause significant respiratory depression, we can actually use the continuous IV infusion in both mechanically ventilated and non-mechanically ventilated patients. And you might be wondering, why would we want to use, a continuous infusion of dexmedetomidine or Precedex in non-mechanically ventilated patients? Well, some patients may develop, acute delirium or ICU delirium. That might, cause a danger to the patient's self. They might, become very agitated. They might, become a danger to themselves, basically having a very, high SAS score or a very high RAS score. And as a result, we might need to treat that. And they might not necessarily be mechanically ventilated patients. They might not necessarily, have any respiratory issue that they need to be mechanically ventilated for. So we can actually put these patients on dexmedetomidine or Precedex without using mechanical ventilation as a support system, which is one benefit of using Precedex. One other consideration that I did not put here, and this is more on the pharmacoeconomic side, is that Precedex is relatively more expensive than some of the other sedation agents that we typically use. It can be, hundreds of dollars of administration per day. So some places have actually restricted the use of dexmedetomidine or Precedex, but it is widely used at many different hospitals. Etomidate is another miscellaneous sedative that we have, and it is a GABA agonist as well. One unique thing is that it has a very, very short onset of action and a very short duration of action. So very short onset within 30 to 60 seconds, short duration within 2 to 5 minutes. It is typically only given as a bolus dose. The reason why we typically give etomidate is for the process of rapid sequence intubation, or RSI. So whenever we're actually planning on putting an endotracheal tube down someone's throat, we want something that's going to work quickly and efficiently to basically, facilitate the process of sticking that tube down the patient's throat. And that process typically only, takes anywhere between 2 and 5 minutes on a relatively normal patient. And that's why we use etomidate for these patients, is because it is relatively short. We can use other agents for rapid sequence intubation. Etomidate is just the preferred one, and typically a lot of times considered a first-line agent for rapid sequence intubation. And this is the only time you will see etomidate is for the use in rapid sequence intubation versus the other sedatives, which obviously have usage as continuous sedatives. It does redistribute rapidly and as a result has a very, very short action. So remember with etomidate, only used for rapid sequence intubation, one of the preferable agents to use for rapid sequence intubation is a miscellaneous agent to an extent, and we give it as a bolus dose. We don't give it as a continuous infusion. Ketamine is another agent that we may use out in practice. It's not used as much as some of the other agents, at least continuous infusion-wise, but it is an agent that is still out there. It is an NMDA receptor antagonist. It does have a short onset of action and a short duration of action, 5 to 10 minutes. It has a loading dose and a maintenance dose that you see here. Its adverse effects include many different things. So you might have psychosis or delirium as a result of being on ketamine. You might have neurotoxicity or neuronal loss from use of ketamine. And you might have hypertension or hypotension as a result of using ketamine. Again, it's not used much as a continuous IV infusion, except for the cases where it might be used in patients with refractory status epilepticus potentially for continuous sedation and continuous infusion to try to obliterate the status epilepticus in refractory cases. A lot of times, a lot of different hospital institutions will consider ketamine more as an anesthetic to only be used in surgical situations as a bolus dose or as a infusion. And that's actually why you might see it be used for rapid sequence intubation. One unique thing about ketamine, in addition to being a sedative, is that it can be actually used for analgesia as well. And it can be used off-label for that analgesia. It's not necessarily a direct indication. It does increase intracranial pressure. So the pressure that you basically have within your cranium and in your brain, it can increase as a result of using ketamine. So this might not necessarily be the best agent to use in regards to, say, if you have a patient that has head trauma. If you have a head trauma, you might already have increased pressure in your brain that is trying to be relieved, and that might not be the best way to use ketamine. And again, with ketamine, its continuous IV infusion does require mechanical ventilation. So now that we've talked about the sedation agents that we have out there, how do we actually use those sedation agents? Like, what do the guidelines actually say? So SCCM, the Society for Critical Care Medicine, actually published guidelines in 2013 and then an update in 2018 regarding the different recommendations that they have for sedation. So typically for sedation, we want the quality and the depth of sedation to be routinely monitored. Typically nurses are doing this very, very frequently in an intensive care unit setting. They might be doing it, every 5 to 15 minutes, making sure that that patient's RASS or SAS is at goal and adjusting the dose of sedative to maintain that RASS or SAS goal, either up or down or at the same level. Wider levels of sedation are associated with improved clinical outcomes, as we discussed earlier. So shorter ICU length of stay and shorter length of mechanical ventilation. So like we said before, our goal RASS is -2 to +1 for light sedation. And for SAS, it's +3 or 3 to 4 for light sedation. And that's another hint, star. Got to know those ranges. Just like we have to know basically the general ranges of our RASS and SAS and what each number kind of means in relation to the middle number, either 0 or 4 for RASS and SAS respectively. We usually want to do analgesia first sedation or analogous sedation in mechanically ventilated patients. And the reason why we do analgesia first sedation, so agents such as fentanyl, hydromorphone, morphine, is because a lot of these patients will be under extreme amounts of stress and pain. And if we can treat that pain with an agent that treats pain, that ironically has an adverse effect of sedation, we kind of basically get two birds with one stone, versus basically being on multiple agents. And it might be okay to be on multiple sedation agents. That's perfectly acceptable. And that's actually how a lot of patients are sedated in practice. But if we want to, start sedating a patient initially, we'll typically want to start off with an analgesic and from the opioid class. And typically we prefer fentanyl. As we discussed earlier, fentanyl has the least amount of histamine release, so we'll have the least amount of hypotension and pruritus that can occur. And as a result, it's kind of our workhorse in the intensive care unit and basically sedation as a whole. So we want to use analgesia first in mechanically ventilated patients. For other patients and procedural areas, the recommendations may vary depending on the particular surgery that you're doing. We're not going to necessarily go into every single type of surgery here, but sometimes, even, simple procedural or surgical settings, might have their own specific preferences for certain sedatives. And this can also be provider specific as well. Some providers might like to use ketamine for intubation. I know I have a lot of physicians at my institution that use ketamine a lot for intubation, and they might actually, use multimodal sedation, such as, ketamine and propofol together as bolus dose for just procedural sedation or even in preparation for intubation. But in general, though, whenever we want to continue that sedation as a continuous infusion in a mechanically ventilated patient, we typically prefer fentanyl first, unless there's a contraindication. We want to use next non-benzodiazepine sedation versus benzodiazepine sedation with or after we basically maximize our analgesia first sedation. So this refers to propofol or dexmenatomity specifically. So basically what can happen is patient gets intubated, for example. If we intubate the patient and we start them on a fentanyl drip after, we might start them at a low dose of fentanyl to basically treat their pain. Once either that fentanyl is maxed out at the maximum dose that we can basically have them on, or the fentanyl is basically at a low, decent maintenance dose, we might use a multimodal strategy of adding propofol or dexmenatomidine on next. Most of the time in practice, a lot of times propofol will actually be used as the second line agent to be added in addition to the fentanyl. Dexmenatomidine can be used in other cases such as ICU delirium, which typically will develop after a few days. It's not necessarily something that develops immediately as soon as you get to the ICU. This takes a little bit of time to develop. So we want to use propofol or dexmenatomidine preferentially second after fentanyl. Now there are some exceptions to this. If you have reasons to be on a benzodiazepine, such as alcohol withdrawal, where we know that basically inhibitory and excitatory neurotransmitters are basically imbalanced between GABA and NMDA, we might want to use a benzodiazepine with alcohol withdrawal first line. Benzodiazepine withdrawal, obviously we would want to give a benzodiazepine first because that would, to potentially treat the benzodiazepine withdrawal. Illicit drug use or illicit drug withdrawal can also be an indication for being on a benzodiazepine. So if you have a patient who is on a lot of stimulatory style illicit drugs like cocaine, for example, or meth, benzodiazepines might be actually preferred there. And then status epilepticus, obviously, y'all have talked about that already prior to this class. Benzodiazepines are typically referred for those cases. But you can also use propofol for status epilepticus as well. Propofol is also an option. These are just examples of when you would potentially use a benzodiazepine over the propofol or dexmenatomidine options. So non-benzo agents better than benzo agents except for the exceptions. And the reason why we prefer propofol or dexmenatomidine is that propofol and dexmenatomidine have less of an incidence of ICU delirium associated with them. Dexmenatomidine actually treats ICU delirium, Propofol may cause ICU delirium with itself, but in general, though, you can use either or for patients. Propofol will actually induce more of a deeper sedation initially, and that's perfectly okay if you want to basically try to initiate with fentanyl plus propofol to try to, induce sedation in patients and then wean the propofol off. Dexmonatomity is a little bit of a more lucid state sedative. It will basically make a patient very relaxed. It might not necessarily make them sleepy though. And in patients that, you need to induce lots of sleep in or more, deeper levels of RAS, you might actually need to use propofol first. You don't necessarily need to know those differences in terms of exam purposes, but that is something that can be considered whenever you are thinking about, propofol versus dexmedetomidine. For exam purposes, what I want you to know is, obviously opioid first or analgesic sedation first, and then you may add on propofol or dexmedetomidine in addition to that fentanyl drip or the analgesic sedation to basically sedate the patient a little bit further. And obviously, you see these bolded exceptions here. Those are very important, hand, star. In terms of the sedation guidelines and recommendations, you want to use sedation protocols and checklists at your individual institution where you will do rotations or work at to facilitate sedation. So you will want to increase sedation dose if your patient is agitated. So say if your patient has a RAS score of +2 to +4, that's obviously on the agitated side, or a SAS score of 5 to 7, that's on the agitated side. You're going to want to increase that sedation dose to basically go back to your goal, which is obviously lower than that +2 to +4 or 5 to 7 for RAS and SAS respectively. For your patients who are too sedated, say if they have a RAS of -3 to -5 or a SAS of 1 to 2, you will probably want to decrease that sedation dose if they are too sedated. And again, remember, lower amounts of sedation are basically associated with shorter length of stay, shorter duration of mechanical ventilation. The exception to this is, again, continuous paralysis. We don't want our paralyzed patients who are on IV continuous paralysis to be lightly sedated. Remember, if you are paralyzed and awake, it is terrifying. It's the worst thing that can happen. Institution of sedation holidays is very important for patients. What a sedation holiday is it's basically trying to wean the sedation down or potentially off at least once a day every 24 hours. Typically, this is done in the morning. And what this does is it helps, basically awaken the patient a little bit while they're, potentially intubated. It does sound like a terrifying phenomenon to occur, but if you wean the sedation down on these patients, you can actually check their mental status, basically of what's going on underneath all of that sedation that's typically being infused. We want to check our patient's mental status because that might, actually, dictate what the prognosis of the patient is. If the patient is unresponsive, off of all sedative agents and they've been off of all sedative agents for a little while, obviously that's probably a bad sign if they're not responsive. If they are, basically a little bit agitative and responsive whenever they have their sedation lowered, that can actually mean that they might be a little bit better off. And it's kind of hard to say, for every single patient. It's not comparing apples to apples, but if you have some response is sometimes better than no response. So we want to try to provide them a break from sedation each day if possible, and not only just to check their mental status, but also to minimize the amount of sedation that we're actually administering these patients. If patients are on sedation for long periods of time, they will obviously have the complications that can occur from that, such as basically storing a lot of this sedation for chronic periods of time in their body. I've seen patients who have been on sedation for days, who may have not qualified necessarily for a sedation holiday because they were too unstable. And whenever you take them off of sedation, it might take them a few days to wake up if they're able to wake up. And that, is not a great thing. And it can be due to the sedation, but it could also be due to their overall mental functioning. So we want to administer these sedation holidays daily if possible. And these sedation holidays are also known as spontaneous awakening trials, or SATs. We just call them spontaneous awakening trials or sedation holidays. So basically lowering the amount of sedation on patients. And then what can happen after you do that spontaneous awakening trial, if the patient is, semi with it, and meets criteria, you can actually do a spontaneous breathing trial on the patient. So if they are mechanically ventilated, you can actually, lower the ventilator settings for them to try to breathe on their own. And if they are breathing on their own, on minimal or no ventilator settings, you can actually try to extubate them. And that's basically, our goal for anybody who gets intubated, is to try to extubate them when possible. Because we obviously see that we can have lots of, adverse effects, side effects, complications from being on sedation, and potentially from having a tube down your throat for too long. It's not a great thing to happen, but it is sometimes medically necessary. This just shows an example of a particular sedation protocol that is used at one particular hospital. I don't need you to know anything necessarily about this slide, but I just want you to know that these sedation protocols exist, and they are hospital or institution specific. A lot of hospitals will actually develop these sedation protocols based off of guidelines. So with that, we've talked about sedation. Now we are going to go and talk about paralysis. And this will be a little bit of a shorter section. So paralysis, 13 to 90% of mechanically ventilated patients receive a neuromuscular blocking agent, or an NMBA. And a lot of times this will actually happen when a patient is getting intubated. When a patient gets intubated, a lot of times we will need to sedate the patient. And then after we sedate the patient, we may need to paralyze them. And the reason why we need to paralyze them may, be to actually facilitate the insertion of that endotracheal tube down the throat. Obviously, you saw in that picture earlier that endotracheal tube is, relatively big. It's not going to fit necessarily like a puzzle piece into that throat. We want to make sure that we're doing it very carefully. And if we paralyze the patient with a paralytic agent, we can facilitate that tube going down that patient's throat. We also have some other applications for NMBAs, or neuromuscular blocking agents, or neuromuscular junction blocking agents. These can improve chest wall compliance and eliminate ventilator dysynchrony. So if you have a patient who is very, very unstable, and we've had them on the ventilator for a while, and they are not able to breathe properly on maximum ventilator settings, then you might actually use a paralytic agent to basically kind of relax that chest wall, to basically try to facilitate the mechanical ventilation of a patient. This is obviously a very complicated process. We don't want to necessarily give this to any patient who has respiratory distress. Some patients may be perfectly fine on the ventilator on their own. I'd say that, in terms of continuous paralysis after they get mechanically ventilated, probably about less than 10% of patients actually need paralysis after that. We might need to reduce intra-abdominal pressures. So say if there's a lot of pressure in the abdomen from something that is within that abdomen, paralysis can actually relax those muscles to basically facilitate the normal processes that are going on in the abdomen, because you have many different organs within that space, and we don't want pressure to be putting too much pressure on those particular organs, because then those organs can fail if we put too much actual physical pressure on them. Another use of paralysis is preventing or minimizing shivering. And one case that this happens in is after a patient suffers a cardiac arrest. So a lot of times when a patient has a cardiac arrest, they might undergo something called a hypothermia protocol, also known as a cold polar for a slang term. And basically what happens is they will actually cool the patient down to try to maintain any neurological status that the patient currently has. Obviously, if you undergo a cardiac arrest, that means that, blood is not flowing through your body, including to your brain. And that can, result in permanent brain damage. And by paralyzing someone, we're actually preventing the shivering that occurs from that hypothermia protocol. And hypothermia, in some studies, has been shown to either maintain or improve neurological status, though that is a little bit debatable. We also use continuous paralysis to prevent elevations in intracranial pressure from airway stimulation. And the reason why you see this picture here, this is actually Neville Longbottom from the Harry Potter series. And if you remember from the first Harry Potter movie, Hermione Granger actually paralyzes Neville Longbottom with the spell Petrificus Totalis. So imagine, paralysis being basically that, basically a freezing of a patient. They're not necessarily sedated. Unless you actually sedate them on your own. And that's why if we do paralyze a patient, we want them to be deeply sedated, because that, sensation of being paralyzed and awake is terrifying. We never want that to happen to anyone, though obviously in the magical world of Harry Potter, that can, potentially happen. So this is always a reminder of what paralysis can potentially look like. You see here basically the neuron and the synapse that you're probably already familiar with, and the neuromuscular junction. Basically the main things to know here is that acetylcholine is released, and that basically goes and binds to the next muscle or to the next neuron to actually activate that receptor and then activate muscle. And as a result of activating muscle, you basically will get, action potentials, and basically muscle contraction potentially, depending on where it binds. The purpose of neuromuscular junction blockers or neuromuscular blockade is to block this process from occurring. And if you block this process from occurring, the muscles do not contract, or they will contract to a lesser extent. And that's ultimately the goal with paralysis, is that we want less contraction. So paralysis indications, like we said before, we want the main indication that we typically see paralysis used for is emergency intubations. So we'll typically sedate the patient first to basically put the patient to sleep. And then we will intubate the patient by sticking the tube down their throat. Before we do that sticking of the tube down their throat, though, we may need to paralyze the patient to facilitate that placement of that endotracheal tube that you see here. So remember, sedation, then paralysis. Acute lung injury or acute respiratory distress syndrome, because remember, paralysis can basically improve chest wall compliance and decrease ventilator dysynchrony, or basically minimize the disagreement between the patient and the ventilator. So if a patient is like trying to breathe over the ventilator too much, or is trying to fight the ventilator per se, is what we call it, and basically, is not really, trying to, breathe with the ventilator, and there's kind of more or less kind of a mismatch per se. In those cases, we might need to paralyze the patient, particularly if they're at very high ventilator settings. Status asthmaticus, so if you have an asthma exacerbation, this might be an indication to paralyze a patient. Elevated intracranial pressures, particularly, after head traumas, particularly. And then, as we mentioned before, therapeutic hypothermia after cardiac arrest. And the only reason we will paralyze someone is to minimize shivering. And just for reference, paralysis in paralysis for therapeutic hypothermia is typically not recommended first line. Typically, we'll do other things to try to minimize shivering from occurring. We'll try to give other agents like Tylenol, Benadryl, other things before we actually try paralysis. But I just want you to know that these are the paralysis indications. You're never going to be asked by a provider, well, do I need to paralyze this person or not? That's more of a provider and a diagnostics decision. It's not necessarily a pharmacist decision about whether or not you need to paralyze someone. So I don't think I've ever recommended to paralyze someone. I might have recommended an agent to paralyze them with, but I would not necessarily say, I definitely need to go paralyze this person. That's happened very, very rarely. The only cases, as a pharmacist where you might potentially recommend this is if you have a patient with acute respiratory distress syndrome, or if you are failing to basically minimize shivering with therapeutic hypothermia. Those are kind of the two, big places that you would basically want to be aware about recommending paralysis. So how do we monitor paralysis? We do peripheral nerve stimulation using a couple of different methods. The most common one is the train of 4, which we'll talk about in just a moment. But this other one that I have listed here is called acceleromyography. It's not used too much, but you see actually how the device is laid out here. They will actually have a device that's connected to a patient's arm in this case, and that device will stimulate the ulnar nerve, producing thumb movement. And the sensor is fixed on the thumb and senses the acceleration of thumb movement. And then this acceleration is then sensed by the displayed monitor. So the monitor will tell you basically how much they're paralyzed. One important thing to note here is that with paralysis, we're trying to minimize muscle function. So anytime that we can minimize muscle function is a good thing, but we don't want to minimize all muscle function because you still need those muscles to physiologically work as a human. So what is train of 4? The most common way of monitoring paralysis is the train of 4, and it's a primary qualitative measurement of paralysis. Qualitative in that it actually measures twitches. It involves 4 supramaximal electrical impulses about every half a second. And you can apply a sensor to the ulnar facial or posterior tibial nerve, or to ulnar nerves as well. Ulnar is probably the most common one that we see. And with those 4 twitches, what is occurring is the machine will actually send an impulse down, or basically a stimulation to twitch, and it will send 4 of these. So basically what you'll actually see is potentially no twitching occurring from the ulnar nerve area, or you might see twitching occur. And it's variable about actually how many twitches you'll actually see. And that's dependent on how paralyzed you have the patient. So remember, you're going to twitch 4 times. It's train of 4. 4 twitches will basically be induced. So if you visibly do not see any twitches or 0 twitches as your patient is paralyzed, that means your patient's too paralyzed. You never want to see 0 twitches happen. So you want to, in that case, decrease the paralytic dose of your patient. If you see 1 to 3 twitches, the paralysis may actually be appropriate. It depends on what goal your actual provider has in regards to train of 4. They might, want 2 to 3 twitches. They might want 1 to 2. But they'll usually provide the goal to you about how paralyzed they actually want the patient. But basically, if they do not, if you see a suppression of a twitch, basically, that you don't see if you don't see any twitches at all, that's too much paralysis. If you see 1 to 3 twitches, that means that there's some paralysis going on as a result of your paralytic agent. Now, if you see 4 twitches aka train of 4, which basically just means that you see all 4 twitches that are being induced by that machine. The patient is not paralyzed enough, and in that case, you might want to consider increasing the paralytic dose. Typically, we monitor train of 4 in hospital patients who are getting continuous paralysis. This won't be used typically for intermittent bolus doses of paralysis that we would use for emergency intubation. The second most common reason why someone would be paralyzed is either acute respiratory distress syndrome, or basically severe respiratory distress, or therapeutic hypothermia after a cardiac arrest. If we see 4 twitches, that basically means that the patient's not paralyzed enough. We want to increase that paralytic dose. 0 twitches means that the patient's too paralyzed. 1 to 3, paralysis may be appropriate depending on what you want. And obviously that has to go off of whatever your provider's goal is. So this is very important monitoring to know. Typically in the hospital, we'll monitor this probably about every hour to 2 hours, sometimes even as more frequent as 30 minutes. Obviously, this does take a little bit of time to set up. You have to obviously attach the sensors to the patient, and it takes a little bit of time. So what paralytic agents do we actually have out there? So we have a few different ones that are out there. We have depolarizing neuromuscular blocking agents and non-depolarizing. So our depolarizing agent, the only one that we have is succinylcholine, and our non-depolarizing agents are the curium agents, or the rhonium agents, basically. Cisatracurium, atracurium, rocuronium, vecuronium, pancuronium. The ones that are most commonly used in practice are succinylcholine, cisatracurium, and rocuronium. Vecuronium is a 4th place agent. I'm not going to necessarily talk about vecuronium specifically as its own individual slide, but you'll be able to see basically how vecuronium compares to the other paralytic agents on a future slide in this presentation. Atracurium is rarely used because it has so much histamine release, and obviously with histamine release we get hypotension and pruritus, as we mentioned with the opioid agents. Pancuronium, the only main case where we use pancuronium is for actually lethal injection patients when it is available. It is the longest acting paralytic agent and can obviously, be very dangerous, as can all of the other paralytic agents. But that's why we're not talking about pancuronium. The 4 that you'll probably see are succinylcholine, cisatracurium, rocuronium, vecuronium. Rocuronium and vecuronium are relatively similar, so we'll focus on the main 3, succinylcholine, cisatracurium, rocuronium. Succinylcholine is a depolarizing neuromuscular blocking agent. It is short-acting, and this is the one thing that is liked much about succinylcholine, is that it has a short duration of action, only 5 to 10 minutes. As a result, we typically use this as the paralytic of choice for an intubation. Remember, intubations typically take, a normal case, 2 to 5 minutes. It's only given as a bolus dose because of its short action. Continuous infusion is not routinely used. We want to watch out, though, for succinylcholine in patients who have renal failure or hyperkalemia. What happens is, with succinylcholine, the depolarizing part of this agent is the most important thing to keep in mind. If you depolarize, that means you're actually stimulating an action potential as this agent is being given. And whenever you stimulate an action potential, if you remember back to basic physiology and pharmacology, when you stimulate that action potential, you have depolarization and repolarization. Whenever you depolarize, sodium goes into most cells, and then potassium will go out of most cells. So if you depolarize an action potential, that will actually lead to an outflux of potassium. And that outflux of potassium will actually go into the serum and cause hyperkalemia. So if you have a patient who has hyperkalemia pre-existing or has renal failure, where they can't eliminate that potassium, that is going to be a big problem with this agent. So you obviously want to watch out for that. Another paralytic agent might be more appropriate. It's also contraindicated in trauma, because if you think about trauma patients, if they have crush injuries or other types of injuries where cells are destroyed, if you basically break apart a cell, you might release more potassium, and that will actually result in hyperkalemia in itself. So we don't use succinylcholine in trauma patients. This can increase intracranial pressure or intraocular pressure, so we don't want to use it in patients, again, with trauma, because those patients will have high ICPs. And it may place the risk of malignant hyperthermia for patients. And malignant hyperthermia is not necessarily a fever, but it's actually an emergent situation. And if malignant hyperthermia is suspected as a result of succinylcholine, the first-line agent for reversal of malignant hyperthermia or treatment of malignant hyperthermia is dantrolene. Not a common agent that you see typically, but it is something that you want to be aware of because it is important to know about. Rocuronium is the next paralytic agent we'll talk about. It is non-depolarizing, therefore you do not necessarily generate an action potential as it's being given. And as a result, you don't have to worry about hyperkalemia or end-stage renal disease as much for this agent. It is intermediate acting, so its duration of action can be between 20 to 35 minutes if you are giving it as a continuous infusion, or 60 to 80 minutes with a rapid sequence IV bolus dose. So obviously it will act longer than succinylcholine. Remember, succinylcholine is short, S for short. We can give this one as a bolus dose or a continuous infusion dose. And one of the major considerations that we have with this agent is it's an alternative to succinylcholine for rapid sequence intubation when succinylcholine is contraindicated. The thing of why we use succinylcholine is short. We only need to have that patient deeply sedated for a short period of time, maybe 5 to 10 minutes max, versus rocuronium, where you're actually going to have to deeply sedate that patient for, potentially close to an hour and a half after you give that rocuronium dose, because we don't want anyone who's being paralyzed to basically be, even lightly sedated or potentially awake. We want them to be deeply sedated. That's why we don't like to necessarily give rocuronium as first line, because the patient will be deeply sedated. Succinylcholine is preferred. But if you have a contraindication or a severe caution to succinylcholine, which would preclude use of succinylcholine, rocuronium or one of the other paralytics like vecuronium might be preferred next as a bolus. Cis-atracurium can also be given as a bolus. It is also non-depolarizing and it is also intermediate acting. One unique thing, and cis-atracurium is also known as Nimbex. So a lot of times we actually see Nimbex being used as a continuous infusion. This is probably the agent of choice for continuous infusion paralysis, though we can use rocuronium, vecuronium, atracurium, or pancuronium as continuous infusions. One thing that's, great about it, it can be used as a continuous infusion, but it's majorly eliminated via Hoffman elimination. And Hoffman elimination is a special type of elimination that's a non-enzymatic degradation. So it's not eliminated renally or hepatically. And that's what makes it a paralytic of choice when you have a patient with either renal or hepatic impairment or both. It's fantastic. Obviously, this is probably why this agent is more expensive than some of our other paralytic agents. It is a fantastic agent because of its Hoffman elimination, which is very important to know about HEN-HANT-STAR-STAR, and we can use it in renal or hepatic failure. This chart gives you basically a comparison of all of the paralytic agents. I don't need you to know necessarily the whole chart, but there are specific parts that I do want you to know about all of the agents. The thing first is the category of how long they act. So succinylcholine, as we said, is short. Rocuronium and cis-atracurium are both intermediate, as well as vecuronium and atracurium, and pancuronium is the longest acting. And remember, pancuronium is the one they use in lethal injection. Elimination. I don't necessarily want you to know the percentages of each of these, but I do want you to know how these drugs are eliminated. Renally, hepatically, or via Hoffman elimination, which is basically cisatracurium and atracurium, and then succinylcholine is done via plasma cholinesterase. It's very, very quick. And additionally, I do want you to be aware with atracurium that histamine release is a major problem with this agent, and obviously that's a reason why we don't really use it too much in practice. I've seen it maybe a couple of times in practice. What are some complications of paralysis? So obviously, if you're paralyzed, those muscles are not working like they normally would. And as a result, you get basically an acquired weakness, and we call this ICU acquired weakness, because a lot of times you'll be getting continuous paralysis in an ICU or intensive care unit setting. You might get deep vein thrombosis or have a risk of deep vein thrombosis because obviously the patient's not moving. And as a result, we want to use mechanical or pharmacologic prophylaxis when it's not contraindicated. So mechanical prophylaxis would be like sequential compression devices that can go on your legs, stockings, though those stockings probably don't do as much as your sequential compression devices. Pharmacological prophylaxis can include heparin 5,000 units sub-Q every 12 to 8 hours. Additionally, you might give enoxaparin 40 milligrams sub-Q daily or 30 milligrams sub-Q daily if your creatinine clearance is less than 30. You might develop corneal abrasions from paralysis. Essentially, it kind of dries out the eyes and can develop these corneal abrasions. So use of artificial ointments such as aqua tears is probably the most common one that is used, is important for regular use in paralysis patients. Typically, we give aqua tears every 6 hours for a patient who's on continuous paralysis. It's not indicated necessarily if they just get a bolus dose of paralysis for, say, emergency intubation purposes. Aqua tears is made up of mineral oil, white petrolatum, and lanolin. You might use eye covers or methylcellulose drops as well. Aqua tears is probably what I have seen the most often in practice. You might have anaphylaxis as you would with any agent, and typically with paralysis, it's typically IgE mediated. It doesn't happen very often though. And then obviously you have awareness during induced paralysis. If a patient is not sedated deeply enough, like I said, that is the most terrifying thing that can happen. So make sure to titrate those sedation levels to deeper levels. So you need to have a RASS of -3 or below or a SAS of 2 or below. Sedation and paralysis administration. So like we've alluded to before, you always want to give the sedative agent before you give a paralytic, especially, if you think about the cases of emergent intubation, you don't want to paralyze someone first and then sedate them after. That is going to be the most terrifying thing that can happen to someone. They will potentially even develop, long-standing psychological issues as a result of that, like PTSD from the situation. Never paralyze someone who is not sedated. It's the most terrifying thing that can ever happen. These drugs are very high alert drugs, and as a result, we need to basically treat them as such. Make sure that you always sedate the patient first. Now, you might not necessarily be the one administering the sedation, but it's always important that you give the proper education to your nursing staff or your providers that basically you need to sedate first and then paralyze after. And make sure that if you are sedating, that you're going to be sedating to a RASS of at least -3 or below, or a SAS 2 or below, so that that patient is deeply sedated so that they do not wake up. And then depending on the kinetics of that paralytic agent, for succinylcholine it's relatively short. But for the other agents like rocuronium, it may be a little bit longer, like potentially up to 80 minutes after you give the rocuronium bolus, that you actually need to deeply sedate that patient. If they are on continuous paralysis, though, they need to be on deep sedation. If they're not on paralysis, though, light sedation is typically the goal. But remember, sedative, then paralytic. Never paralytic and then sedative. And never paralytic on its own, ever. These are the references for today's talk. And we're going to go back to the questions that we talked about at the beginning. So we had our 62-year-old female coming to the ED with shortness of breath. She was diagnosed with heart failure, has been eating at McDonald's every day, probably taking in a lot of salt, and probably got very fluid overloaded from all the salt she was taking in, because remember, fluid always follows salt. Her vital signs were significant for a borderline blood pressure, elevated respiratory rate, elevated heart rate, and a low oxygen saturation. Past medical history is significant for end-stage renal disease. That's important to keep in mind because that might put her at risk of hyperkalemia. She requires intubation and then mechanical ventilation with need for sedation and paralysis, essentially due to that intubation. So if you're going to intubate this patient, which medication sequence demonstrates proper sedation and paralysis for the patient's intubation? Cisatracurium, then fentanyl, propofol, then dexmenatomity, succinylcholine, then morphine, or medazolam, then rocuronium. The answer here is going to be medazolam, then rocuronium. So remember, we want to sedate first and then paralyze. So options 1 and 3 are basically wrong because these are paralytics first. The other option is 2 sedatives, propofol and dexmenatomidine. We don't even have a paralytic agent here. Additionally, if you were to flip the situation on number 3 and do morphine then succinylcholine, that would actually be problematic because your patient does have end-stage renal disease. Maybe they might have hyperkalemia or be predisposed to hyperkalemia because of that end-stage renal disease. We might not necessarily want to give succinylcholine to a type of patient like that because succinylcholine is depolarizing and can obviously depolarize that action potential, release potassium, and cause hyperkalemia to occur. And we don't want a hyperkalemic emergent to occur as a result of a drug that we're giving them. So the best option here is medazolam, then rocuronium. We want to sedate first, then paralyze after. Now remember, we said that, obviously we can sedate with anything for intubation purposes. Etomidate is typically preferred, though some providers may have their individual preferences over what sedative to use. Typically, though, remember, etomidate is only reserved for RSI. After intubation, HP requires continuous sedation. Which of the following is most appropriate first-line continuous sedation for HP, or the patient HP? Dexmenatomidine, fentanyl, lorazepam, morphine. Answer here is fentanyl. Fentanyl is preferred here because we set analogous sedation or analgesia for sedation. So basically, we would want to use an opioid first. We don't want to use morphine because remember, morphine has the most histamine release associated with it, therefore causing hypotension and additional increased risk of pruritus. Dexmenatomidine and propofol are second-line agents and should be used after at least you start a fentanyl drip. Lorazepam is typically not preferred as first or second line, but may need to be used in patients who have specific indications like benzo withdrawal, illicit drug use, or status epilepticus, or alcohol withdrawal as well. Though we can also use it if they are refractory to other sedation methods. And then what is the most appropriate RASCAL for HP? +2 to +4, 0 to +2, -2 to +1, or -3 to -5. So the answer here is -2 to +1. And this would obviously, preface, that they're being continuously sedated after the fact, because we just had mentioned that they're going to be continuously sedated. You would want them to be at a -3 to -5, potentially whenever you're intubating the patient. So obviously, upon induction, -3 to -5 might be most appropriate because they might be paralyzed. If you are going to eventually continue a paralytic agent continuously, -3 to -5 would be the most appropriate. +2 to +4 would indicate extreme agitation. That would not be great for a RASCAL. 0 to +2 would be awake to alert to basically agitated, and we don't want the patient to be, extremely agitated. A little bit restless or +1 is acceptable because restlessness can be a little bit tolerable for some people. Think about restlessness as basically like whenever you wake up in the morning. You might not necessarily, like waking up, but it is something that, it's acceptable. All the way down to -2, which is a light level of sedation. That's going to be most acceptable here for this patient. -3 to -5 only if they're paralyzed. So with that, our talk on sedation and paralysis is done. If you have any questions, feel free to email me, and have a great day. Thank you.